Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 558 of our pharmacotherapy series, which majors in schizophrenia. The next question reads: what other metabolic effects need to be monitored in JPJ while she is receiving antipsychotic treatment? What are the risks of these effects in patients receiving these medications? JPJ, as with all patients receiving antipsychotics, is at risk of developing potentially significant weight gain, glucose irregularities including diabetes mellitus type 2, and dyslipidemia, especially hypertriglyceridemia. The risk varies among the agents, with second-generation antipsychotics generally thought to be at a higher risk than with first-generation antipsychotics. Risperidone, which JPJ is currently receiving, is often considered to be at a mid-level risk of these effects compared to some of the other second-generation antipsychotics. Other possible risk factors include the patient's diet and exercise, family history of diabetes and cholesterol problems, and others. The psychiatrist decides to change JPJ from risperidone to an agent with a lower risk of hyperprolactinemia. He starts JPJ on olanzapine, titrating up to 20 mg per day while removing the risperidone. What would be the appropriate monitoring for JPJ upon initiation of olanzapine? As olanzapine has a high risk of causing metabolic adverse effects in patients, JPJ should be monitored closely for the development of these effects. Her weight should be checked very closely, especially at baseline and over the first few months of treatment. Monthly, if not more frequently, weights should be measured during this time. In addition, her serum glucose and/or HbA1c along with her serum lipid panel should be checked at baseline and then in 3 months for any changes, with an interim serum glucose measurement around 1 to 2 months. Her blood pressure should also be monitored for any changes, especially if her weight increases significantly. If any increases or abnormalities are noted in these parameters, they should be addressed appropriately before becoming a medical concern. After 2 months on olanzapine, JPJ returns to the clinic complaining that she's always eating and doesn't fit into her clothes from last summer. Her weight today is 151 pounds, with a corresponding BMI of 25.9 kilograms per meter squared, an increase from her weight prior to olanzapine of 139 pounds, with a corresponding BMI of 23.9 kilograms per meter squared. JPJ's parents are also concerned as they have never seen her eat this much in her life. She is currently doing well on the medication, with no psychotic symptoms noticed over this time. They ask whether this appetite and the weight gain are from the olanzapine, and whether there is anything that can be done about it. Olanzapine could certainly be the cause of her recent weight gain, because it has one of the higher risks of causing weight gain among the second-generation antipsychotics. A 12 pounds weight gain is certainly possible with this medication, as JPJ, and her parents, has noticed an increase in her appetite since starting the medication. This makes it even more likely olanzapine is involved. Although there are no proven treatments for antipsychotic-induced weight gain, there are some interventions that could be implemented. JPJ should be given an appointment with a nutritionist to review her diet, and she should also be encouraged to increase her exercise on a regular basis, whether at a gym or even by adding 20 to 30-minute walks 4 to 5 days a week. A month later, JPJ returns to the clinic. Blood work done a few days ago shows her fasting serum glucose to be 214 mg per deciliter, which is an increase from 132 mg per deciliter 4 months ago. Her HbA1c has also increased from 5.9% to 7.1% over this time. A serum lipid panel shows her total cholesterol is 256 mg per deciliter, her direct LDL cholesterol is 117 mg per deciliter, her HDL is 34 mg per deciliter, and her triglycerides are 997 mg per deciliter. Are these changes potentially related to JPJ's antipsychotic treatment, and if so, how should they be managed? Increases in serum glucose and lipids, especially triglycerides, are possible with second-generation antipsychotics, and olanzapine in particular. As her glucose and A1C have increased since starting the medication, this makes it highly likely this is the cause. Although JPJ's LDL and HDL cholesterol measurements are not ideal, they are not as concerning as her very elevated triglyceride level. At this high of a level of triglycerides, there is the concern of possible pancreatitis. JPJ should be asked about any upper abdominal pain or other possible symptoms. Although we could treat her increased serum glucose and lipids with appropriate medications for each concern, another consideration would be to change JPJ from olanzapine to another second-generation antipsychotic with a lower risk of metabolic problems. This would need to be done after considering the risk of JPJ's possible psychiatric decompensation from changing her antipsychotic treatment. We will now discuss medical comorbidity. Currently, metabolic syndrome is seen as a major concern when treating schizophrenia, and it is recommended that patients receiving second-generation antipsychotics must be routinely monitored for weight gain, changes in fasting serum lipids, or signs of glucose dysregulation. Some estimates of the prevalence of metabolic syndrome in patients with schizophrenia range from 18.8% to approximately 40% of those tested. As medication-naive patients are already at a high risk for developing metabolic syndrome, we should strive to minimize the chance or worsening their situation. Furthermore, since weight gain with antipsychotic medication and its secondary metabolic complications tends to occur rapidly, patients should receive more frequent assessments for this when they are first started or switched to a new antipsychotic medication. Medication use evaluations to make sure this necessary monitoring is performed may be helpful. Moreover, Effective pharmacotherapy carries with it a potential for serious adverse metabolic effects such as obesity, hypertriglyceridemia, and resulting glucose dysregulation, as well as movement disorders such as akathisia, drug-induced Parkinsonism, and tardive dyskinesia. One study showed metabolic disorders occur more than 3 times, 3.7, with a 95% confidence interval 1.5 to 9, as much in patients with schizophrenia as compared to non-psychiatrically ill controls. In fact, cardiovascular disorders are the main reason patients with schizophrenia tend to die at a younger age than their peers. Another concern is that, along with known genetic factors, metabolic syndrome issues such as increased weight, serum leptin, lipids, and glucose are known risk factors for venous thromboembolism, abbreviated as VTE, which also may occur in association with antipsychotic pharmacotherapy. The most established link is to the use of clozapine, which is one of the most metabolically problematic agents. However, even more metabolically benign antipsychotics may eventually be linked to the increased occurrence of venous thromboembolism. Pulmonary embolism is a well-documented variant occurring with antipsychotics. As venous thromboembolism related to antipsychotics is likely rare, the benefit-to-risk ratio should be kept in perspective. Other cardiovascular effects can be problematic when utilizing antipsychotic pharmacotherapy. Of concern, olanzapine, risperidone, and quetiapine have been associated with a 3-fold increased likelihood of cerebrovascular accidents, abbreviated as CVAs, and transient ischemic attacks during the first 6 months of treatment in elderly patients. Other antipsychotics have also been implicated. Such events could relate to the slightly higher risk of death in elderly patients receiving these medications. As a result, all antipsychotics have a black box warning from the US FDA regarding an increased risk of cerebrovascular accidents in elderly patients taking these medications. We will now look at neuroleptic malignant syndrome. Neuroleptic malignant syndrome, abbreviated as NMS, is a rare, but potentially fatal complication of antipsychotic therapy that can occur due to treatment with any antipsychotic or abrupt cessation of a dopamine agonist. Therefore, early recognition and management are crucial. There are numerous diagnostic scales to ensure accurate diagnosis of neuroleptic malignant syndrome for research purposes, but the most widely utilized in clinical practice is the DSM-5 criteria. Neuroleptic malignant syndrome is associated with high fever, that is 103 degrees Fahrenheit to 104 degrees Fahrenheit, muscular rigidity, altered consciousness, and highly elevated creatinine phosphokinase, abbreviated as CPK, often greater than 1,000 micrograms per liter. Other signs are drooling, difficulty swallowing, fast heart rate, greater than 100 bpm, profuse sweating, incontinence, and labile blood pressure. It is treated by immediate cessation of antipsychotic therapy, supportive care, and the administration of medications such as dantrolene sodium, bipridone, or bromocriptine. Combination antipsychotic therapy was found in 39% of all neuroleptic malignant syndrome cases. Some believe that physical exhaustion and dehydration predispose a patient to develop neuroleptic malignant syndrome, so it is important that patients on antipsychotics be cautioned to take proper caution in hot weather. Also, the effects of antipsychotics on the hypothalamus, which regulates temperature and food intake among other activities, and the body secretion, drying activities of anticholinergic medications increase the danger of heat exhaustion in these patients. So there you have it. Our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arora, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 559.